Bismillah. Good day, everyone. First of all, I'd like to extend my sincere thanks to Dr. Amr Husseini, my mentor and our Academy President, and also our esteemed board members, Dr. Jamila Kori, Dr. Khalid Hassan, and Dr. Hanan Abdelaziz, and Dr. Rasha Samir. I'd like also to express my gratitude to our moderator today, Professor John Sire, as well as our distinguished guest speakers, Dr. Wen Deng and Dr. Ashita Gupta. My name is Dr. Mahmoud Sheikh. I'm a nephrology consultant and World Kidney Academy educator. Today, I have the pleasure of presenting a case entitled When Histopathology Was Not Enough. Without further ado, let's get started. So we have a young 21-year-old gentleman whose medical history is actually quite limited. Apart from treated hyperthyroidism and well-controlled hypertension, he had no known chronic kidney disease. The story begins after an admission for influenza A. Initially, his kidney profile appeared just beyond normal level with a creatinine of about 110 micromoles per liter. But what makes this case interesting is what happened afterward. Rather than recovering completely, his renal function continued to decline over the following month. Now, a mild rise in creatinine after an acute illness isn't something that would immediately raise alarm bells. We see that fairly often in clinical practice, but in this patient, the decline was accompanied by something much more concerning. He had significant microscopic hematuria together with nephrotic range proteinuria exceeding 6 grams per day without further previous baseline. Yet despite that degree of proteinuria, he didn't have the classic nephrotic picture. There was no edema, his serum albumin remained relatively preserved, his lipid profile was normal, and he had no systemic manifestations to point out toward an autoimmune, inflammatory, or any infectious process. So now we are faced with an interesting paradox. We have a very young patient, progressive kidney dysfunction, nephrotic range proteinuria, persistent microscopic hematuria, but remarkably few clinical clues to explain what's driving the disease. And that's exactly where I'd like you to pause and think. If this patient walked into your clinic today before seeing a biopsy or ordering serology or going far for genetic testing, what would be on top of your differential diagnosis list? The first diagnosis many of us would naturally consider is IgA nephropathy. The history of an upper respiratory tract infection together with hematuria in a young adult certainly makes that an attractive possibility. However, the amount of proteinuria is somewhat greater than we would typically expect in most cases. Focal segmental glomerulosclerosis is another strong contender. The degree of proteinuria certainly fits. The early kidney dysfunction could be also explained by a primary podocytopathy, but persistent microscopic hematuria is a little less characteristic and makes us pause before settling on that diagnosis. Given the combination of proteinuria and declining kidney function, immune complex diseases such as membranous nephropathy or membranoproliferative glomerulonephritis also deserve consideration, though neither one is strongly supported by the clinical picture alone. Of course, before labeling anyone with a primary glomerular disease, we have to exclude secondary causes. Lupus nephritis, infection-related glomerulonephritis, or monoclonal gammopathy-associated kidney disease all belong on comprehensive differential diagnosis, even if the patient's age presentation makes some of them less likely. And then there is one diagnosis that, at this point, could easily be overlooked. A hereditary nephropathy such as an Alport syndrome, the patient has hematuria, significant proteinuria, and progressive kidney dysfunction, but without striking family history or obvious extrarenal manifestation. There isn't yet enough clinical evidence to confidentially move genetics on the top of that list. So based on the information available today, I think most nephrologists would agree that there isn't a single diagnosis that clearly stands out. This remains a broad, challenging differential, and the next logical step is to let serology and kidney biopsy narrow our thinking. So we performed a comprehensive laboratory evaluation. The autoimmune workup was entirely unremarkable. There was no serologic evidence to support ANCA-associated vasculitis, anti-GBM disease, lupus nephritis, or complement-mediated disorders. In parallel, infectious causes were carefully excluded. Virus serologies, including Hep B and C and HIV, were all negative, making infectious-related glomerular disease considerably less likely. We also searched for another secondary etiologies that can present with heavy proteinuria, including diabetes, monoclonal gammopathies, and systemic disease. Again, none of these investigations revealed an alternative explanation. So where did that leave us? At this stage, the probability of primary glomerular disease became much higher. The next diagnostic step was no longer a laboratory test, it was obtaining tissue. Let's see what the biopsy revealed. Let's begin with the light microscopy findings. The biopsy demonstrated both global and segmental glomerulosclerosis, indicating that chronic injury had already developed despite the patient's young age. In addition, the remaining glomeruli showed mesangial expansion with increased cellularity accompanied by mild glomerular basement membrane thickening and mild tubulointerstitial fibrosis. Importantly, there was no presence, no endocapillary hypercellularity, suggesting that we are not dealing with an aggressive inflammatory glomerulonephritis. Now let's move to the immunofluorescence findings because this is where pathology appeared to provide a clear answer in such case. Immunofluorescence demonstrated dominant mesangial IgA deposition with the combining C3 staining as a codominant, while IgG and IgM C1q were essentially absent or minimally present. To further characterize the biopsy findings, we applied the Oxford MST classifications, which, as you know, remains the standard histopathological scoring system for IgA nephropathy. The biopsy was classified as M1, E0, S1, T1, and C0. Overall, the Oxford score was entirely compatible with a mild form of IgA nephropathy. So at this point, everything appeared to fit. The biopsy supported IgA nephropathy, the Oxford score was internally consistent, and the pathology report was entirely defensible. But as clinicians, our job isn't simply to accept diagnosis that fits. Our responsibility is to ask one more question. Does the diagnosis explain the entire patient? And in this case, the answer was not quite. The first thing that caught our attention was the patient age. At just 21 years old, he already had established chronic kidney disease with chronic histological changes. That's certainly possible in IgA nephropathy, but it's not the pattern we commonly expect, particularly in someone with no previous history of kidney disease. The second concern was the severity of proteinuria. Nearly 7 grams per day is substantial. Yet, when we looked back at the biopsy, the degree of structural injury didn't seem sufficient to fully account for the clinical picture. There was also a subtle but important clinical-pathological mismatch. Histologically, this looked like a relatively moderate or mild form of IgA nephropathy. Clinically, however, the disease was behaving much more aggressively than pathology would predict. Whenever I encountered that kind of discordance, I became uncomfortable accepting the first diagnosis at face value, because one of the most valuable lessons in nephrology is this: when the clinical phenotype is more severe than the pathology suggests, don't ask whether the biopsy is wrong, ask whether the biopsy is incomplete, and that's exactly what happened here. Rather than closing the case with straightforward diagnosis of IgA nephropathy, we asked different question. Could IgA deposition be a secondary finding while the true underlying disease had not been discovered? That single question completely changed the direction of our case. Unlike light microscopy or immunofluorescence or electron microscopy, allows us to examine the kidney at the ultrastructural level. It doesn't just tell us what it deposits within the glomerulus. It reveals the architecture of glomerular basement membrane, the integrity of podocytes, and subtle structural abnormalities that simply cannot be appreciated by routine histology. So the question was no longer, is this IgA nephropathy? The question became, could be there is underlying hidden or combined hereditary basement membrane disorder, as an example, that coexisting with or even masquerading as IgA nephropathy. That was the question electron microscopy was asked to answer, and as you will see on the next slide, it provides the first clue that completely changed our understanding of this case. So here is where the story took an expected turn. The first finding was diffuse thickening of glomerular basement membrane. While that by itself is relatively non-specific, it immediately prompted a closer examination of the basement membrane architecture. And that's where the key observation emerged. The GBM demonstrated extensive splitting and multilamination of the lamina densa, creating the classic basket weave appearance that every nephropathologist associated that with type 4 collagen disorder. For me, this was a pivotal moment in the entire case, because a basket weave GBM is not feature of primary IgA nephropathy. It immediately raised the possibility of an inherited basement membrane disease, most notably Alport syndrome. In addition, there was diffuse food process effacement. Now, food process effacement can certainly be seen in IgA nephropathy, particularly in patients with heavy proteinuria. So by itself, it wasn't the defining feature. The defining feature was the architecture of the basement membrane, and this is an important distinction. The IgA deposits explain that we were seeing on immunofluorescence. The electron microscopy began to explain why this kidney looks the way it did. At that moment, our work in the news fundamentally changed. We were no longer asking where this patient had IgA nephropathy. We were asking whether the IgA nephropathy represented an associated finding, while the primary disease was actually Alport syndrome from the start. Electron microscopy didn't replace the biopsy, it completed the biopsy, and once we recognized that possibility, there was only one definitive step remaining. We had to interrogate the genome. So once electron microscopy demonstrated classic type for collagen abnormalities, the next question was no longer whether we should pursue genetic testing. The real question was how could we justify not doing it? Our primary focus was the type 4 collagen genes, specifically COL4A3, COL4A4, and COL4A5, which together accounts for vast majority of hereditary GBM disorders. Given the patient age, sex, phenotype, COL4A5 was particularly important because X-linked Alport syndrome is the most common form of the disease and typically presents more severely in affected males. But obtaining a molecular diagnosis is about much more than simply putting a name on the disease. It directly influences prognosis, guides therapeutic decisions, determines transplant consideration, and perhaps most importantly, allows us to identify at-risk relatives through cascade family screening. In other words, genetics wasn't performed to satisfy our curiosity. It was performed because it has the potential to change the management of both this patient and his entire family. So, with a strong clinical suspicion and clear molecular target, we proceeded with genetic testing, and the results finally answered the question that histopathology alone couldn't. And the results confirmed exactly that the patient was found to carry homozygous likely pathogenic variant in COL4A5 gene. Now, why this is so significant? COL4A5 encodes alpha chain of type 4 collagen, one of the essential structural components of glomerular basement membrane. Glycine residues are highly conserved within the collagen triple helix, and substituting glycine with another amino acid disturbs the stability of that structure. That precisely the mechanism of underlying X-linked Alport syndrome. The fact that this variant was identified in the homozygous state is also clinically important. As they know, males with X-linked Alport syndrome generally have a more severe phenotype because they lack normal copy of the gene to compensate. So this molecular finding didn't simply support our suspicion. It establishes the diagnosis. The patient has X-linked Alport syndrome with IgA nephropathy. We initially diagnosed was not the complete explanation for his disease. This case beautifully illustrates something we are encountering more frequently in modern nephrology practice. Genetic kidney disease and immune-mediated glomerular disease are not always mutually exclusive. They can coexist, and when they do, histopathology alone may identify one process by completely missing the underlying genetic disorder. In other words, the biopsy gave us the phenotype and genetic test gave us the diagnosis. At that moment, when the case truly became an example of precision nephrology. So after integrating the clinical presentations, the kidney biopsy, the electron microscopy finding, and finally the molecular results, we were able to reconstruct the complete diagnostic picture. The patient didn't have isolated IgA nephropathy. The primary disease was X-linked Alport, caused by homozygous likely pathogenic COL4A5 variant. The hereditary type 4 collagen disorder was the fundamental process driving the progressive chronic kidney disease, persistent hematuria, and much of proteinuria that we have observed. At the same time, the biopsy also demonstrated mesangial IgA deposition. Now, this is an important point. Finding IgA deposits doesn't necessarily mean that IgA nephropathy is the primary disease. Mesangial IgA deposition may coexist with other kidney disorders, and in this patient, it represented an associated pathological finding rather than the principal diagnosis. In other words, both diagnoses were correct, but they were not equally important. One explained the biopsy and the other explained the patient. And that distinction that ultimately changed our management plan. Now let's walk through how the management evolved over time, because I think this is where the real learning point lies. Initially, based on the clinical presentations and the preliminary biopsy interpretation, the patient was managed as presumed primary IgA nephropathy. Supportive therapy was started immediately, including RAS blockade, aggressive blood pressure control with the target systolic blood pressure below 120, together with lifestyle modification. Because the patient had nephrotic range proteinuria, diffuse food process effacement, therapeutic trial of steroids was then initiated. At this stage, this was reasonable decision at the available pathological finding favored immune-mediated IgA nephropathy. However, after several weeks, the expected response simply didn't occur. There was no meaningful reduction in proteinuria, kidney function failed to improve, and after the electron microscopy finding, the genetic testing became available. Immunosuppressive therapy was discontinued because there is currently no evidence supporting steroids or other immunosuppressive agents in genetically confirmed Alport syndrome. Continuing them would only expose the patient to unnecessary toxicity without proven benefit. Finally, management was redirected toward evidence-based supportive care. This included optimized RAS blockade, strict blood pressure control, initiation of SGLT2 inhibitors for kidney protection, and dietary sodium restriction. The focus was no longer suppressing inflammation, but slowing disease progression and preserving kidney function. Now the question is, can Alport and IgA nephropathy coexist? The answer is yes, and it's a diagnostic trap. IgA deposits can occur secondarily in Alport syndrome due to altered GBM composition and immune dysregulation. This creates a misleading immunofluorescence picture that satisfies IgA nephropathy criteria. The key distinction in true IgA nephropathy, the GBM is normal on EM, and in Alport syndrome, GBM abnormalities are always present. Going to the emerging evidence, this is a recent systematic review was published this year, including 81 patients from 72 families, confirmed that the coexistence of IgA nephropathy with Alport syndrome is a genuine but heterogeneous clinical entity that is frequently under-recognized. While essential IgA deposition may initially suggest IgA nephropathy, electron microscopy and ultimately genetic testing are often required to uncover the underlying type 4 collagen disorders. This case mirrors the evidence perfectly. Histopathology identifies the associated glomerular disease, electron microscopy and molecular genetics revealed the primary diagnosis. And also this article, persistent hematuria in the presence of glomerular membrane abnormalities should always prompt electron microscopy and genetic testing even when IgA nephropathy has already been diagnosed. And family screening proved invaluable, identified additional affected relatives with microscopic hematuria, chronic kidney disease, and early sensorineural hearing loss, allowing earlier recognition of the disease within the family. The combination of glomerular membrane abnormalities and essential IgA deposition should always raise suspicion for an underlying call for related nephropathy rather than assuming IgA nephropathy alone explains the entire clinical picture. And also this study shows that coexisting genetic kidney disease, particularly called for related Alport syndrome, is common in familial IgA nephropathy and may explain the severity of the disease. IgA deposits not exclude an underlying hereditary nephropathy, making genetic testing, especially in familial cases or a typical presentation, essential for accurate diagnosis, prognosis, and family screening and safe living kidney donors. So once we establish the diagnosis of X-linked Alport syndrome, our responsibility extended well beyond this individual patients because unlike most acquired glomerular disease, this diagnosis has important implications for the entire family. As you know, COL4A5 is located on X chromosome. As a result, affected males who are homozygous for the mutation typically develop the most severe phenotype, with progressive kidney disease and substantial lifetime risk of kidney failure. Female carriers, however, should never be considered unaffected due to random X chromosome inactivation. Their clinical presentation can vary considerably, ranging from isolated microscopic hematuria to significant proteinuria, chronic kidney disease, and in some cases, progression to kidney failure. Understanding the inheritance pattern is therefore essential for appropriate counseling. Each son of carrier mother has 50% chance of inheriting the pathogenic variant and being affected, while each daughter has 50% chance of inheriting the variant and becoming a carrier with variable clinical expression. But perhaps the most important message is this: molecular diagnosis doesn't end with this patient, it begins with the family. Every first-degree relative should be offered genetic counseling, appropriate genetic testing when indicated, and at very least, screening with urine analysis, assessment of kidney function. Early identification allows us to initiate kidney protective therapy, monitor disease progression, provide accurate reproductive counseling, and avoid preventable complications, particularly in potential living kidney donors. Making the diagnosis only the beginning, the real value of identifying Alport syndrome lies in how it changes long-term management. These patients require structural follow-up aimed at slowing disease progression and detecting extrarenal manifestations before they become clinically significant. Every 3 months, we monitor the fundamentals like serum creatinine, estimated GFR, proteinuria, blood pressure. These parameters allow us to assess disease progression and optimize RAS blockade and SGLT2 inhibitors, which remains the cornerstones of kidney protection alongside with the other supportive care. Every 6 months, we broaden our assessment. Because Alport syndrome is multi-system disorder, patients should undergo periodic audiologic evaluation, as sensory neural hearing loss is one of the earliest and most common extrarenal manifestations. On an annual basis, ophthalmologic examination is also recommended to identify characteristic ocular findings, particularly anterior lenticonus and retinal abnormalities. This is also an ideal opportunity to revisit family screening and ensure that at-risk relatives have received appropriate genetic counseling and testing. Finally, we should always think ahead. As kidney function declines, early planning for kidney replacement therapy is essential. Referral for transplant evaluation should occur well before end-stage kidney disease develop, allowing adequate time for preparation and donor assessment. An important point to remember is that Alport syndrome doesn't recur in the transplanted kidney, making transplantation the preferred renal replacement therapy for most patients. However, careful evaluation of potential related donor is critical to avoid in selecting an affected family member. So in many ways, the genetic diagnosis doesn't simply tell us what the patient has, it provides a roadmap for everything that follows after that. As you see, this case generated rich discussion for this case among internationally nephrologists on ACE and discussion community when I presented the case on them. Each expert approaches the case from slightly different angle, and that diversity opinion was incredibly educational for me and for other attendants. It remind me that most of best learning happens not from having the right answer immediately, but from asking the right questions. Thank you all very much for your time, your attention, and your kind participation. I hope I was able to provide clear, practical overview of this fascinating case and highlight the value of integrating histopathology, electron microscopy, and genetic testing in modern nephrology. I also hope to see you all in the World Kidney Academy Genetic Kidney Disease Workshop, which will be held at the end of August. It will be a great pleasure to have you join us for what I believe will be an exciting and highly interactive educational experience. Thank you once again for listening. Goodbye and have a wonderful day.